you everyone for joining us today. This is the first session of our CKD e-learning series after 4 years hiatus. We're welcoming Dr. Peter Birks, Omo Enilama, Dr. Michelle Wong, and Janelle Yu to discuss their project looking at optimizing post-acute kidney injury care. This session will cover the impact of acute kidney injury, AKI on clinical outcomes, explore barriers to post-AKI management, and discuss province-wide improvements in the managing of post-AKI care within the primary care setting. I will hand this over to them to continue with our session.
Great, thank you so much. So I'll get started first. As Sidoni said, there's 4 of us speaking today. I'll let all of us 4 speakers will introduce ourselves individually and share, our affiliations and any conflict of interest that need to be declared. So again, I'm Omo Enilama. I am a project coordinator with the BC Kidney Research Unit. So yes, like Sidoni said, we are talking today about our post-acute kidney injury project. So we'll just go over, before we get started, we'll do a land acknowledgement. So just next slide. So I would just like to share that a lot of us here are speaking from the shared and ceded and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. If you know the land that you are residing and working in, please feel free to put that in the chat if you know that. Next slide. So I think Sidoni already said the objectives, but just again to run by quickly, we'll talk about the implications of AKI, the importance of follow-up, some of the barriers that we've seen, as well as our initiative to improve that. Next slide. So this is a project that has been spanning a couple years now. So the first part of the project, what we did, members of our team kind of identified gaps in post-AKI care. And this is through discharge reviews as well as focus groups. And my colleague Peter is going to talk a little bit more about that. And then we also developed educational resources and tools in order to help with these gaps. And again, we'll talk more about it as we go through the slides. Now, the current phase of our project, we are looking to implement some of these strategies and tools that we'll highlight at some specific hospital sites. So currently we have 3 sites that we are planning to do that in. And then we also want to evaluate, how this is working. And then in the future, we're looking towards spreading these tools across the hospitals across the province and making sure that our initiatives are sustainable. Next slide. So if you haven't already done so, please complete the pre-webinar survey. You can, put your phone up to the screen to do the QR code to get the link. And it's pretty quick and simple. And so now I will pass things off to Peter Birks.
Hi, everyone. I'm Peter. I'm one of the nephrologists at Royal Columbian Hospital and Fraser Health, and also do some work with BC Renal with an interest in acute kidney injury and chronic kidney disease. So I'm going to give some background definitions regarding acute kidney injury and some of its consequences to sort of underscore the importance of why we're doing this project in the first place. So acute kidney injury is really an abrupt change in kidney function. Strict definition is even a small increase in creatinine by 26.5 micromoles per liter within 48 hours, or greater than 1.5 times baseline, which is thought to occur within 7 days. It's not really a diagnosis in itself, in that you need to figure out what the cause of the acute kidney injury is. There's an underlying etiology for the AKI. It's very common. Often, most data would say 20% or more in hospitalized patients, and many start and can occur in the community, and many acute kidney injuries are preventable. So those are some factors to look at. And we are finding more people surviving episodes of acute kidney injury in hospitalization. So we now have more survivors who may be dealing with some of the consequences. And then on the right, there's just the KDIGO staging. So there's 3 severities: mild, moderate, and severe, or 1, 2, 3. And that can be characterized really by the extent of the creatinine rise compared to baseline, with stage 1 being 1.5 to 1.9 times, stage 2 to 2.9 times baseline creatinine, and stage 3 can be either 3 times higher than baseline creatinine or an absolute value. That's American units, but I believe that's like 350 something cutoff in Canadian units, micromoles per liter. Or if they need dialysis, that's a severe or stage 3 AKI. There's also some urine output criteria, but of course that's less commonly being monitored except for in the hospital setting. Next slide. This is a graph just showing what can kind of happen, and there's a timeline at the top with acute kidney injury. So it's firstly showing that AKI can occur in really like up 20% or even up to 80% in some hospitalized populations, like in the ICU, for example. So at the top, some patients recover, and some of the patients who recover may even progress just to normal health with no kidney implications or downstream implications. But we do know with the dotted lines below that even when AKIs recover, it does increase the risk of cardiovascular disease, chronic kidney disease, and mortality. Below, there's some degree of patients who will not recover over weeks. Those patients can still recover over months, or they can end up with some degree of kidney impairment or chronic kidney disease. And then people with acute kidney injury, whether recovered or not, can have those increased risks of cardiovascular disease, mortality, and recurrent acute kidney injury. You'll see at the very bottom middle, there's a abbreviation AKD, and that's to outline this entity called acute kidney disease. So we did the definition of AKI. Those are the people with the abrupt changes in kidney function happening within 48 hours to a week. And we know that chronic kidney disease is sort of renal impairment that persists beyond 3 months, but everything in between those weeks to months is characterized by this acute kidney disease. So that's not as like commonly known term, but it is something of interest, and we thought to highlight in this graph. Next slide. So there's many consequences and possible downstream complications of acute kidney injury. So proteinuria is one, and we know that can increase the risk of kidney disease progression. High blood pressure, new or worsening congestive heart failure. Recurrent episodes of acute kidney injury is much more common in those who have already had one. Rehospitalization, adverse drug effects, and a number of other factors and symptoms. Okay, next slide. And some of the long-term consequences, you can get new or progression of CKD. So someone who has CKD, they're at increased risk of AKI, and then their AKIs can also lead to more progression of their CKD. So it can be a bit of a vicious cycle. Increased risk of cardiovascular disease. We talked about the short-term consequences of hypertension and kidney disease and heart failure, and you can get the longer-term worsening cardiovascular disease risks, and then of course frailty and death. So a lot of things that we want to modify and prevent as much as possible following acute kidney injury, which is one of the reasons for doing this project. The guidelines for acute kidney injury, a little bit out of date. KDIGO, which is our sort of international guideline committee, released some statements in 2012, just essentially saying that if someone's had acute kidney injury, they should have screening within 3 months for new or worsening chronic kidney disease with essentially lab tests, kidney function, and urine studies. But KDIGO, one of the other sort of international bodies, recommended, this has to be a little bit done on a case-by-case fashion. The more severe acute kidney injuries, you may not want to wait a full 3 months, whereas the less severe ones probably don't need as close follow-up. But there's no sort of specific timelines recommended. Next slide. This has been looked at more recently, a mixed method study discussing with nephrologists and primary care practitioners, came up with the consensus that they thought that lab should be followed up sort of within 2 weeks of a hospitalization with acute kidney injury. And the need for nephrology-specific follow-up should be directed by patient-specific factors and sort of risk factors for downstream kidney disease. Collaborative care was very important and involving other team members such as pharmacists. But they also outlined there's a need for updated guidelines and resources for management following acute kidney injury. Other expert panels have recommended that in severe acute kidney injury requiring dialysis, labs should be monitored within 7 days of discharge. But again, these are sort of just statements made, no kind of formal guidelines. In reality, we know that patients with acute kidney injury, they often don't get those recommended follow-ups. About 60% of patients, this is US data, following hospitalization for AKI, only about 60% had their labs checked within 3 months of discharge. and even a small minority actually had urine testing, and we are learning more and more the importance of, proteinuria following AKI and in CKD with respect to risk. So an important thing that's being done in a very small minority of the time. Okay. We wanted to get some more local data on what's happening with discharge communication following acute kidney injury, because in kind of my own experience and in some of the previous literature, often acute kidney injury happens as part of a complex hospitalization. It may recover, it may not, and sometimes it doesn't even make it into the discharge summary, in which case the outpatient practitioners and primary care practitioners may have no idea it even happened. So we looked at, we identified over 1,000 acute kidney injuries on the medical and cardiac wards at St. Paul's. And we did a random sample of 300 AKIs and actually screened their discharge summaries for sort of the adequacy of AKI documentation. So what we found on the right, you can see the number of patients along the Y and the stage of AKI along the X. So the documentation was incomplete, and sort of the mild AKIs, about 62% of the discharge summaries did not mention the acute kidney injury. It does increase in terms of how much was documented in more severe acute kidney injuries, which makes sense. But even in the severe ones, stage 3, triple of the baseline creatinine or dialysis, only about still 75% mentioned it, 25% did not mention the acute kidney injury. And then it's more than just mentioning the AKI, it's sort of what we can do after. So we looked at on the left of the discharge summaries that did have some laboratory recommendations mentioned in the discharge summary. Only about 61% mentioned the specific labs that should be monitored. And only about 50% mentioned whether a requisition was even given or not. And about 82% had some sort of lab follow-up plan mentioned. So there could be a lot of confusion to someone following up if, labs are recommended, but you don't know whether the rec was given or not, or maybe they weren't recommended at all. So all important aspects that aren't sort of complete. And in terms of follow-up with practitioners, of those that even mentioned a follow-up, about 75% did mention follow-up with a primary care practitioner, but a very small minority on the far right, probably 10% or less, mentioned any form of nephrology follow-up, and that didn't really differ by severity of acute kidney injury. Okay, next slide. Another similar study run in Ontario that I was also a part of looked at a sample of discharge summaries in another province in Canada, in Ontario, and they sort of looked at different factors that they thought were important in a post-AKI discharge communication, things like the AKI happened, what caused it, what was the severity, what to do with labs and meds, and who to follow up with. Pretty similar findings, somewhat incomplete documentation. More mention of AKIs when the AKI was more severe. The etiology had fairly incomplete documentation, as did the other factors. So we're seeing, at least in 2 different provinces, pretty clear evidence of unsatisfactory discharge communication surrounding AKI. Some of the elements of an ideal AKI discharge communication would be some of the things I mentioned. Did the AKI occur, how severe it was, because we know the severity is associated with some of the consequences. What labs are recommended following, what medication changes were made, because we know holding medications in acute kidney injury is important, but also some of these medications are important to eventually restart because they may have other benefits, and what the follow-up plan is, as well as specifics surrounding that. What are the benefits of good discharge communication? So this has been found to be associated, good formal documentation of AKI has been found to be associated with reduced 30-day mortality following kidney injuries. It has also been associated in studies with reduced risk of rehospitalization and with more timely medication review, kidney function monitoring, and patient education. We, as part of our group here, performed several focus groups across the province, including nephrologists, primary care, pharmacy, patient partners. And we found a lot of useful information, but these are just a few of the tidbits that we wanted to highlight. The primary care practitioners emphasized challenges with care coordination and care complexity following acute kidney injury. Lack of sufficient discharge communication was mentioned, as we've shown in those studies. It was also highlighted in the focus groups. And a need for more specific guidance among like timing of laboratory follow-up, when to see the patients, medication advice, as many medications are stopped and started, and when nephrology needs to be contacted or formally consulted. And then patients, they also mentioned, they often weren't even aware they had an acute kidney injury. It may not even have been mentioned to them, or maybe it was mentioned in a way that it was kind of jumbled with a bunch of other information and they didn't recall it. They also mentioned, if you tell them things while they're hospitalized and sick, the sort of ability to comprehend is less. And then there's a lack of sort of education, resources and tools after that hospitalization. And they really want some more self-management tools. They of course want their caretakers to be armed with as much information as possible, but they want to actually figure out how they can optimize their self-management. A little bit more about medications. As everyone knows, a lot of medications, especially ones that can affect the kidneys or affect blood flow to the kidneys, etc., are held during kidney injury, usually appropriately. Those can include ACE inhibitors, ARBs, diuretics. We wanted to highlight a little bit, it's easy to start a medication, but to stop a medication, but when should they be restarted and what's the importance of that in AKI? You can go to the next slide. There's fairly compelling literature to suggest that following acute kidney injury, if someone has a strong indication to be on some of these cardioprotective medications like ACE inhibitors or ARBs, if they're stopped and not restarted, that can actually increase their risk of downstream mortality. It's associated with increased risk of mortality, and continuing to hold it is not associated with any prevention of subsequent acute kidney injury. So it is important to get people back on these important medications eventually, but guidance is required. Okay, so I'll pass it over to Michelle to talk some more specifics about our work and our implementation study.
Okay, thanks, Peter. So my name is Michelle Wong, and I'm a nephrologist in the community. And I'm also a researcher, and I'm part of the SFU UBC Implementation Science Training Initiative. It's one of my disclosures, and this project is the focus of that implementation science training. And also wanted to disclose this project is funded by Shared Care BC. All right. Peter gave you an excellent introduction to identifying the gaps in care and AKI discharge communication. So the next step was really finding out how we could help patients and primary care providers and generate generalizable knowledge about the strategies we use to improve post-AKI care. And so I'm just going to move to the next slide. So in terms of the area of implementation science, the formal definition is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. So it's really sort of addressing that gap between what we know and what we do. And a sort of a simpler way of sort of defining implementation science is when we know we have an effective treatment or intervention or practice, we call that the thing. And so in this case, we know that good discharge communication about AKI can improve clinical outcomes. So that would be our thing. And then implementation science is really the stuff that we do to help clinicians do the thing. So these are the sort of strategies that we're going to talk about in the next few slides. And then implementation science is really the study of how we do the thing, how we help clinicians to do the thing. So that's sort of a simplistic way of looking at implementation science. And so this is a roadmap of our Post-AKI project. And I'll kind of go through a bit of the steps of our project. So the first is really defining the why and the what. So the why is identifying the gap in care, which Peter went through very clearly. And then the what is our AKI communication and education package. And so we did focus groups in order to find out more about barriers and facilitators to optimal post-AKI care. And this work was guided by some theories, models, and frameworks that we use in implementation science to help us guide our questions to uncover those types of barriers. So we really identified domains in the areas of knowledge and skills that were main barriers to optimal post-AKI follow-up, as well as beliefs about capabilities and general habits. So those are what we uncovered from the focus groups in the multidisciplinary focus groups. And then the next step is identifying the implementation strategies to address those barriers. So we were able to directly map those barriers to evidence-based change strategies. So we produced an AKI discharge / sign-off note template, and that included all the sort of vital information about the acute kidney injury. And we knew we needed to also try to increase the knowledge. So we developed a lot of educational materials, including a website on BC Renal about acute kidney injury, medication guide, as well as this webinar here. And for patients, we developed an educational handout and a website that's patient-facing. And for hospital nephrologists, who are the people delivering the AKI communication education package, we wanted to help motivate them to carry out this intervention by having local champions to motivate them, training in terms of how to use the template, as well as a checklist to make sure they delivered all the components of the implementation strategies. And so our research question is really to ask what implementation strategies help to deliver or prove delivery of the AKI package. And we're doing a feasibility study in 3 hospital sites in BC, including Royal Columbian, where Peter is, University Hospital of Northern BC in Prince George, as well as St. Paul's Hospital. And these sites will be sequential in terms of the timeline. And we are doing what's called a hybrid type 3 observational study design, meaning that we will focus on implementation outcomes, but we're also going to assess effectiveness in terms of the AKI knowledge and satisfaction, as well as do patients actually get follow-up after discharge, and as well as follow-up labs. And we have what we call a mixed methods approach, meaning we'll have both qualitative and quantitative data. So our outcomes are going to be focused on the implementation. So in terms of the reach, how many patients with AKI did we reach? How the physicians, did they adopt the implementation strategy? Did they carry out all the components, which we call fidelity? And maintenance, did they continue it long-term? The effectiveness I mentioned. And then the implementation determinants are going to be through focus groups, really, to find out more about the context, feasibility, acceptability of carrying out these implementation strategies. And then next is really scale up and adapting to other settings and making sure our approach is sustainable. We do have a pediatric nephrologist, Terry Mammon, also involved in our project, so we hope to be able to adapt it to other settings, including pediatric population. Okay, and just a reminder of our sort of broad interest holders who we've involved throughout the whole project. Of course, our patient partners and caregivers and our nephrologists and primary care providers who've been involved in this project, but also our project manager, Omo, our allied health partners who've helped to develop the materials, the educational materials, and the support of administrators has been absolutely essential, including the hospitals, the health authorities, BC Renal, having IT support to help us with our discharge template incorporation into the electronic health records, as well as our funders and implementation science specialists who have guided us on this journey. All right, and so I'm going to hand it over to Janelle Yu, and she's going to talk more about the implementation tools that have been developed for patients and providers. And I'm just going to see here. I'm going to just move on here to the next. Okay, all right. I'm gonna see if we can give her control to share anything else she wants to. Janelle, I just want to check in here.
Oh, can you see my screen?
I can see your screen. Yep.
Perfect. Thank you, Michelle. So I'm Janelle. I'm one of the GPs helping out on the project here. So for me, one of the hardest things is to come away from a lot of these talks with resources and where to go from there. And a big part of that for me is resources and being able to access guidelines and referral guidelines after the fact. And so a really good website is BC Renal. So if you can see here, this is the landing page for BC Renal, a lot of really great resources. And then especially under health professionals here, you can see a number of different topics, clinical resources for this topic here today. Acute kidney injury is what we'll be looking at. And again, that's through BC Renal, health professionals, and then the topic here, acute kidney injury. For me, these are kind of the two big ones that I like to look at. So nephrology referral criterion timeline is always something, if I'm not sure if a patient should be referred after hospital admission for this, there's great resources to just check back on, see what is recommended. And then also the other part is to take a look at the criteria that make up different risk levels for AKI. On the side here, you'll also see these quick links, which will link to medication guidance tables, and then how to restart different medications that patients might have been on previously and were stopped in hospital by nephrology. So medication guidance tables. This is a pretty comprehensive chart. So many patients, especially, with kidney issues, are on a number of concurrent medications. And it's always hard to know, how much you should be, if they should be held, restarted, when to restart, what you should retest. And for me, I found this was a very comprehensive and easy to access resource to see, yes, metformin, very common diabetic medication, and looking at, GFR, when to retest the GFR, at what levels you should be looking at decreased medication dosages. And so this is under the medication guidance. Going back, also post-AKI medication restart. Really easy to look at flow chart. When should we be restarting these big medications like the SGLT2 inhibitors? And then, what sort of electrolytes we should be monitoring. When might they need a little bit more investigations as well. So that's kind of the resources that I'd just like to share with the group for the GP kind of primary care perspective.
Great. Thanks, Janelle. I'm just going to go back to sharing, and then we can also go through the discharge template as well. So I'll just go back to that. Just hang on a moment. Okay, is my screen showing up okay here? Okay, great.
Yeah.
All right. So yeah, I'm happy to go through this. So this is the sign-off/discharge template, which is incorporated into electronic health records either as a template or can also be used as a macro. But basically, it contains most of the essential AKI related information at the top here. So the parts in red are where the hospital physician is going to fill in a bit of data about the severity of AKI and the cause of AKI, whether or not they require dialysis, what their peak creatinine was, and the most recent creatinine. And then in terms of follow-up recommendations, in terms of the level of risk of complications of AKI, we have a check box here so people can indicate low, moderate, or high risk. And the recommendation in terms of the timing of follow-up and repeat serum creatinine is different by risk level. And we have a recommendation to check the urine ACR after 3 months post-discharge for all patients. And then there is an optional section on the medications that may need to be reevaluated, specifically in relation to the AKI things that might have been changed or held that need to be readdressed. So a list can be inserted in the right in page 2. And there are links to the medication guidance table and the restart algorithm that Janelle showed. There's also links to the Pathways BC there. That's just another route to the BC Renal website. And we have a referral recommendation listed there as well, and also contact for the race line if GPs have any questions. As well, there's a link to a survey to as we want to gather feedback on how people find the template. Okay. And this is just, Janelle already went through this. The medication guidance table has been beautified a bit on the right side there. So that will be the version that will be on the website soon. And this is the educational resources we developed for patients and caregivers. So on the BC Renal website, there's also a patient-facing website. And so it has this handout. We designed our intervention so that this handout would be given to the patient at discharge. And it just explains that they've had acute kidney injury, what are the risks, and what are the follow-up recommendations. And we also have a QR code so that we can have feedback from patients as well on the handout. There's also a QR code to the website on BC Renal. So it is shown here on the right. It has a lot of information about the kidneys in general, what is acute kidney injury, medication management, and nutrition. And there's also a section on mental health supports, and those are types of informations that our focus group participants who were patients and caregivers said that they wanted more information on. So we definitely took that into account. And as I mentioned, there is a Pathways BC AKI pathway that is still under construction at this time, but just wanted to let you know that the same information will be summarized there, and the links to BC Renal will also be there, because I know that Pathways BC is a very often used resource amongst primary care providers. Okay, and I just want to go through a little bit about our study design in terms of how we're evaluating our intervention. And so essentially, at each site, we're starting off at Royal Columbian Hospital. The nephrologists will be consented to participate, and during their week on service for inpatient consultations, they'll be instructed to use the discharge / sign-off note for any patients they're signing off on. And so they'll use the template, and they will click a box that allows the patient handout to be attached to the discharge package. So the patient will receive that handout and the link to the toolkit. The patient will also receive the AKI discharge / sign-off note, so that if they're unattached, they can take that letter to any healthcare provider they're going to follow up with after discharge. And then the family physicians are going to receive that discharge note. And as I mentioned, there'll be links to the toolkits on the website there. So at each site, we're going to have our feasibility study over 1 month. And as I mentioned, the strategies that we're using to help nephrologists actually deliver this intervention are, having that template in the electronic health record, having a local nephrology champion at each hospital, and we're going to do some in-service training with them, and we have a checklist to make sure that they deliver all the components of that intervention. And then 3 months later, on the right there, we're going to be doing follow-up focus groups or interviews just to evaluate the whole process of what was feasible, acceptable, how people experienced delivering this intervention or receiving this intervention. And our goal is also to do a chart review to assess if the patients had follow-up with their GP, and if they had outpatient lab testing of creatinine and urine ACR. At each step of the way, there's surveys. So if you receive a discharge note, we really appreciate having completion of the survey to give feedback on that. And as well, patients will be asked to fill out surveys on their impressions about the patient handout. Okay, and then in terms of our evaluation, as I mentioned, it's a mixed method study. So our implementation outcomes the patient's reach, the adoption by the physicians, fidelity, sustainability. The hospital nephrologists are going to be collecting data on their own use of these of the discharge template and the patient handout. As I mentioned, we have a lot of surveys, and we can also look at website hits on the BC Renal website. The effectiveness outcomes, so that's where we want to do the chart review to see if patients are having follow-up visits with their GPs and follow-up testing of their kidney function and urine ACR. As well, we're doing the surveys to assess knowledge and awareness of AKI. And then the implementation determinants are really the qualitative data and from the focus groups or interviews where we want to find out a bit more about how the implementation strategies actually worked. So that's our project in a nutshell. Future directions, as I mentioned, we want to expand this to admitting physicians across specialties in adult, pediatric, potentially postpartum settings. And we can also look at expanding our initiative to include community pharmacy, as they are the ones evaluating their medications after discharge. And as well, our goal is to scale up to province-wide and potentially beyond. But first, we're currently carrying out our feasibility study. Okay, and so just to wrap up, and we're happy to take any questions. So our current hospital discharge summaries demonstrate suboptimal documentation of AKI, which Peter went through. Findings from our focus groups showed a need for a detailed follow-up plan and guidance at the primary care level, as well as additional educational resources for patients and primary care providers. So our implementation project will deliver patient and provider-facing strategies to ideally improve post-AKI follow-up care in BC. And as I mentioned, we've got our 3 sites, which will be rolled out sequentially. And we've involved broad interest holders and are receiving feedback at all phases of the project, which is really important in order to improve the quality of implementation. Okay, thank you so much. I just wanted to list our acknowledgements here, BC Renal, Share Care BC, all the healthcare providers and patient partners involved in our steering committee and focus groups, our site champions, Reichert and Associates have helped us develop our surveys for program evaluation, and the IT teams at Royal Columbian who've helped us to develop a template, and our implementation science training initiative mentor. And I just wanted to remind you, we do have a post-webinar survey here. So we'd really appreciate if you're able to fill that out, and this will help us greatly for our study. And we have our list of contacts here if you have any questions, but we're happy to take any questions here in the chat, or if you're able to unmute yourselves, just leave that up.
So I see one of the questions was about having a copy of the discharge instructions. So I think, like we mentioned, if you go to the BC Renal website, we do have the information there of, the essential components of a discharge summary, and we have a link or an attachment there of like the template as well. But I can also just put the link in the chat to make it easier. So just give me a second and I will do that. Okay, I've put that in the chat. Any other questions?
I just also put the AKI website
Page.
link on there
Great,
as well.
thank you. So I'm not seeing any other questions come up in the chat, but we do have like our contact information, and I'll put my email in the chat in case. Oh, I see a question. Great. Okay. I'm hoping for the sign off discharge template that is one off your slides. I think the link that I sent should be that one that is in the slides. Let me just double check that link. Oh, it requires you logging into BC Renal. 1 second. What we can do is I can just put, I'll just put my email in the chat and you can send me an email and I'll just send it to you directly. We'll just do that to make it easier. Yes, that one.
And just,
yeah.
Sorry, Omo.
No, go ahead.
You finished what you were going to say, then I'll.
I was just saying, I think there's an issue with the website, because if you try to view it on the website right now, it's okay, I see your email. I'll just send you an email. Okay, sounds good. But yeah, right now on the website, when you try to do it, it makes you log in. So we'll work on that to make sure that it's more accessible. And then I will send you an email, Susan. Thank you.
I was just going to mention that that template is in its kind of, we've gone through several iterations, but it's about to be sort of trialed at several sites to see, are people finding it user friendly? Does anything need to be modified? So I wouldn't necessarily consider it to be in its final iteration, just in case that has any effect on including it in protocols or anything like that. So we'll be doing our feasibility studies. There may be some alterations. So certainly checking back in the future too to see if there's been any modifications based on all the feedback we've gotten.
Yeah, Peter, that's a really good point. We, I guess, went through a large process with the working groups to review all our materials and sort of resolve any conflicts and things like that. But it is something that is can continue to be improved, based on feedback and focus groups that we'll have in the future. So it's something that will evolve likely, and we may need to adapt it for different settings. And so that's also a key part of implementation science, the adaptation part. So how the intervention is delivered in different sites may be a little bit different. But yeah, thank you so much for your comment here, Susan, in terms of the highlighting acute kidney injury in the discharge notes.
Thank you. Okay, do you think it's fair to kind of sign off at this point if there's no